But it's been a pretty active field. And so I'm going to talk a little bit about the newborn screening piece, but also just give you a few other updates related to adrenoleukodystrophy. So let's see if this works. Doesn't work. Is it moving? Yeah, I think I got it. Okay. Oh, okay. Okay. Yeah, just briefly, disclosures. So just I think everybody in the room knows about ALD, but just a brief recap of what we're talking about when we talk about the different forms of ALD. So it's an X-linked disease, but it does affect females as well, and there are several phenotypes in males and in females, as you can see here. In males, almost everyone develops adrenal insufficiency, while it's extremely rare in women. Only a handful of women that have developed adrenal insufficiency over the years. And then about 35 to 40% will develop the childhood-cerebral ALD, which is a pretty fatal form of this disease if untreated. And was the adrenal insufficiency and childhood-cerebral ALD were the driver for developing newborn screening. Women usually don't get affected until adulthood, mid-age. Well, my age, I guess, is the proper term. But about at least half of women seem to develop some level of myeloneuropathy. The phenotype is a little different than in males. There's a more prominent sensory ataxia and pain component. There's also a dyskinesia component in women seen, although we don't know exactly what the prevalence of that is. Adult cerebral ALD is very rare in women, but somewhere between 20 to 60% in adult males, unfortunately. So focusing on childhood cerebral ALD, again, this is, you all know, but this is the most severe form of the disease that led really to development of therapies many years ago. Here's just an example from Hugo Moser showing how within a few months, an 8-year-old loses his ability to write. You can see on the left side, this is a third grader, and then on the right side, how he lost it within a few months. So it's a rapidly progressive disease, and we know that by the time you have any neurological symptom, it's too late for interventions currently. We also know that the MRI changes significantly precede neurological findings, and the more we now do newborn screening, the more we see that there's a lapse up to perhaps 2 to 3 years between the very first MRI changes and any neurological signs. And so that really requires that we diagnose this disease early. Most importantly, as many papers have now shown, this is one larger paper by the Minnesota group, showed that if you want to do an intervention, the earlier you do, the better. And therefore, the ideal candidate is somebody with a small and gadolinium-enhancing brain lesion, but who has no symptoms, no neurological symptoms. And we use the MRI severity score developed by Daniel Less. If your Less score is greater than 9, you have terrible outcome, which you can see on the left side. And so ideally, we would like to transplant these kids when the Less score is only like 1 or 2, so very early on in the disease, just when they show enhancement. And then when you do it in that stage and you have a matched donor, you have great outcomes. As you can see on the right side, vast majority of those children are surviving and are stable without neurological symptoms. In addition, when was it? September 2022, the FDA approved the first lentiviral gene therapy for adrenoleukodystrophy. This is ex vivo gene therapy with ex vivo transduction of CD34 positive cells and then autologous transplant of the patients. There are some issues that have emerged with this approach, mostly myelodysplastic syndrome that has been seen in a subset of these kids and is still under close observation. But because of these treatments, it was and the fact that adrenal insufficiency can be deadly if it goes uncovered, if a child presents with a febrile illness in the emergency room in hypertensive shock, there was a great push for many years to develop newborn screening. The assays were developed many years ago. And thanks to Elisa Seeger, this map looks currently amazing. This is the most recent map she sent me last week. I don't think she's here yet, but I thought she was going to come to this conference. And as you can see, the vast majority of the United States currently is green. So we are almost there. There's a very small percentage that you can see here that is still not not screening, but there is discussions with all of those states, and hopefully it's going to happen for the next couple of years. So the entire country is going to be screening for ALD. And I really would like to thank Elisa and everybody else who was involved in this effort to push this forward. That's just mind-blowing when I look at this figure today. So with newborn screening, what we are seeing is findings of very early disease stages. And this is work done by Eric Malak, and he spent most of his time at Florian Eichler's group before he joined us. And so my screen is shaky. I hope that one is not. Okay, it's not. So here you see two kids, two cases, one in the posterior part of the corpus callosum, the splenium, and one in the genium of the corpus callosum, where you see initially the MRI appears normal, and then you get this really tiny little thing. Not sure if it's a lesion or not. And then again, a few months later, you see, yes, there is a lesion there. And the same here in the genome. And so this is what we are now seeing. We're starting to see these tiny little lesions. They are the size of a dot. And we are not used to that, because in the old days, we used to see big lesions, when the kids were symptomatic. And even when you started doing the family screening, extended family screenings for many years, oftentimes we wouldn't catch it this early because we wouldn't usually screen these boys early enough. And so this has helped us to get some idea about how early do we need to start imaging kids, and how fast does this thing get worse. We are hesitant to do bone marrow transplantations or gene therapy in anybody who doesn't show gadolinium enhancement. Gadolinium enhancement is a sign of blood-brain barrier breakdown. If you have blood-brain barrier breakdown, we believe that in that moment is when your transplanted cells will actually be able to go and modify the disease course in the CNS. If you don't have blood-brain barrier breakdown, you may actually not be able to do that. And so it's critical to have GAD enhancement. And so the question is, when you see these tiny little lesions, how long does it take for them to actually enhance? And it's not easy to answer until we had newborn screening and until we started getting this follow-up data. And so now that we're getting this follow-up data, this is again work done by Eric Malak. We see that on average, it's about 6 months from the first time we see something on the MRI until the follow-up. Now, keep in mind that many times we don't repeat the imaging more frequently than 6 months, so we don't exactly know. But it does seem like it takes somewhere on that order, about half the time, to show the first GAD enhancement. And once the gadolinium enhancement starts, it seems like the disease progression from an MRI lesion perspective rapidly progresses as well. Although we are still far away from having symptoms, when we see these tiny lesions, these kids are neurologically completely silent. And so, but this gives us the opportunity to really go in early. And from the data that we have had so far, we haven't seen anybody who has developed cerebral ALD, unprovoked cerebral ALD, I should say, before year age 2. And I say unprovoked because there is at least one case that we know of where a child went into an adrenal crisis and suffered severe hypovolemic shock, consequently had hypoxia in the brain and hypoglycemia in the brain, and developed rapid demyelination starting from the cortex downwards. And so that was a very different presentation. And it was, I think, because of the secondary insult that the child sustained. And that child was very young. And so I won't count that as a normal, but like every child otherwise that we know of has been 2 years or older that had clearly gadolinium enhancing lesions. Now, people always argue because they might have seen some ADC changes or some FA changes in younger kids. We don't really call that cerebral ALD. I think that's part of the challenge that we're having now with a lot of screening happening, a lot of radiologists looking at these MRIs, is that they see some mild T2 changes and they may or may not call that cerebral ALD. And it's difficult because you have terminal zone myelination in the developing brain. You still have areas that are myelinating normally, and so their T2 signal is brighter. So it's not that straightforward, although it's easier than in Krabbe, I suppose, but it's still challenging. And so based on this data, there was originally a consensus group that was actually led by Hunter Soap. and the LCNs, and then more recently another group that was an international consensus group using a Delphi technique, looking at what should we recommend in terms of follow-up. And this is the publication, and here is basically in a table listed in the publication what is recommended internationally. Now, there are some fine-tuning things with each of these aspects, and I want to briefly just talk about them. So with childhood cerebral ALD, the consensus has been to start screening around age 2. Now, we had said in the original paper between 12 and 18 months, and the driver there was that oftentimes we have parents who are really anxious. And we had a lot of back and forth about that. And that was what was decided in the first paper. But realistically, we really don't see this until 2 years of age. From 2 years of age on, the prevalence of cerebral ALD rapidly inclines, and it peaks around 7 years of age. And then after 12 years, it really goes down and rapidly declines. And so between 2 and 12 years, the international recommendation is to image these kids every 6 months based on the data that I just showed you. And then after 12 years of age, we recommend imaging every year, annually. The one thing that the international consensus didn't really get into too much detail is whether they should also get a GAD study or not. And that has to do with the fact that we don't want to, of course, give too much gadolinium to kids. At the same time, we also don't want to anesthetize them too often. And so in an ideal setting, you would have the MRI done at a center where you have live interpretation of the MRI. And if you have live interpretation of the MRI, then you could technically look at it and say, well, there's no GAD enhancement there. The kid is sedated. We still don't need to give him. So I'm sorry, there's no lesion there. Even though the kid is sedated, we're not going to give him the GAD. Now, realistically, that almost never happens. And so in the kids that are anesthetized, our practice, for the most part, to actually stay with them without GAD every 6 months, just because we don't want to re-anesthetize them in case we do see a tiny lesion. And so we do that until they no longer need sedation. And then once they don't need sedation, it gets a little easier. There's also insurance that often steps in and says, well, you just imaged the kid. Why do you want to repeat the MRI? And they refuse it. In terms of the AMN, we really just monitor them neurologically. But what is important that this table may misrepresent is that we are greatly concerned about adult cerebral ALD in men, in males. And so we do repeat the imaging every year perpetually. And unfortunately, it never really ends. So we had a patient who recently passed away about 9 months ago at age 72. At age 69, he was playing golf. He was not using a cane. He had no Addison's disease. And the only neurologic abnormality that he had was mild sensory ataxia and loss of vibration sense. And then he developed cerebral ALD with bad, rapidly progressive cerebellar lesions and died. And so he didn't have anything when I saw him at age 69. He developed the first abnormal MRI around age 70. So it can happen that late. And there was no precedent to it. He didn't have a stroke or anything, although that's felt to be a big risk factor potentially in older men. In terms of adrenal screening, the general recommendation is that you basically start screening them for adrenal insufficiency as early as possible. We have now seen kids that are around a month old or a little more and already have basically laboratory evidence of adrenal insufficiency. And so there are clear guidelines that have been published by Molly Riegelman, and we recommend screening. We recommend screening every 3 to 6 months initially, at least during childhood. Because it can happen anytime and it's easily treatable. In terms of screening for signs of gonadal deficiency, we do see testosterone deficiency in a big chunk of the males, but only in adults. And the general recommendation in this consensus was not to routinely screen for signs of testosterone deficiency laboratory-wise, but just wait for neurological or any sort of symptoms related to testosterone deficiency. The challenge with that is that they may have, most men do have some fatigue, many have erectile dysfunction. And so we are pretty easy on testing that when we are gonna check their adrenal function anyway. So we generally end up screening that pretty often in my clinic, at least, or in our clinic. In women, no imaging is recommended because the chance of childhood cerebral is extremely, extremely rare. There's one case that I know of that was Q-dex inactivation. There are very few adults that have developed these very peculiar cerebral forms of the disease, but it's a handful of people, like less than 5, that have been ever documented. So we don't screen with MRI. We also don't screen for adrenal insufficiency unless they have symptoms. But having said that, a lot of women come to our clinic and complaining about fatigue, this and that, and lots of symptoms that could be potentially adrenal insufficiency. So we do, in our clinic at Kennedy Krieger, at least screen them at baseline, usually for signs of adrenal insufficiency. Some other centers may choose to do an MRI in these women at the very first visit. And I think that's acceptable because they come in with neurological symptoms and they just want to make sure it's really related to ALD. So I wouldn't go against that. One thing I want to talk about briefly and then shut up is the gray zone project that was started last year. So like any other disease, once we start newborn screening, we are on having a population of patients that don't have really elevated values and are not really normal, so they're in that gray zone range. And then you do gene sequencing, and then they end up having a variant of unknown significance. So now you have somebody who has a gray zone value of their C26, and they have a VUS. And so what do you do then? And so this project is led by Stefan Kemp and others here, but it's really trying to take the top 100 known VUSs and try to understand better what's happening there. It's going to take a long time until we actually know the clinical relevance of this, because even if you show biochemistry being normal or abnormal, it's still going to be hard to really let these patients go and call them benign. But one of the discoveries that he made is, and that's really important, that's if there's one thing to take from this call, especially for the newborn screening labs, is this information that the Stefan Kemp in 1999 developed the adrenal leukodystrophy ABCD variant database. And the ABCD variant database is far more comprehensive what we can see in ClinVar. He has been trying to keep track of every single variant across the world and trying to understand if those are pathogenic or not based on the family history in those kids and based on their biochemistry and their phenotypes. And so it is a very large database now with over I think altogether, if you include the misses and the deletions and all that, it's about 4,500. It's live, it's actively updated every time. And many of the variants that are called in ClinVar VUS, he knows are not VUS. If you go to the ALD database, they're actually not VUS. They're actually pathogenic. So it would be wrong to just look at ClinVar, which is a lot of what a lot of genetics labs do, and then calling a variant the VUS. They should have really looked into the ABCD1 variant database. And so I think that's a critical aspect of what's happening. And so it's a free website, and he's maintaining it, and I hope he will do it forever. Just want to finish up just talking about what's happening in terms of the therapy side beyond bone marrow transplantation and ex vivo lentiviral gene therapy. So there's a bunch of things going on. There's a clinical trial right now of AAV9 for adult men with AMN, where basically you're trying to replace the missing ABCD1 gene. It's intrathecally injected. And the hope is that it's going to help with the myeloneuropathy to basically stop disease progression. It's currently a phase 1 study at UMass, only on one side. And then there is a whole group of people, including us, who have been over the years trying to figure out methods to overexpress ABCD2. So ABCD2 is a homolog of ABCD1, does basically the same function, great amount of homology. And what has been shown by Johannes Berger's group is that in macrophages and monophagocytic cells, which are thought to be the key drivers in ALD, at least in the cerebral form, ABCD2 is actually downregulated. And so the idea has been, okay, if you could upregulate ABCD2, we could bypass the very long-chain fatty acid dysfunction. And so one of the ways to do that is with thyroid mimetics. So there's a trial right now with that, which is in phase 1 stage. And then another drug that has been called leviglitazone that has been tested in several trials, and the verdict is still out there. And that's a PPAR inducer. It's not a direct ABCD2 inducer. We have developed in our lab a ABCD2 upregulator ASO that looks pretty promising in fibroblasts, but hasn't reached clinical stage yet. And then there are some other methods that are hopefully going to hit the clinical trial stage soon. One is inhibiting the very long-chain fatty acid synthesis called the enzyme there, the critical enzyme is called ELOVL1. And so if we can block this ELOVL1 enzyme, that should basically decrease very long-chain fatty acid synthesis. Has not been in clinical trial yet. Well, lorenzazole actually does that, but we all know that lorenzazole doesn't work. Another approach that is hopefully going to hit again clinical trial stage very soon is a modulation of TNF pathway and inflammatory pathways. Another approach that is about to start in Spain is a trial with dimethyl fumarate in Spain as an NRF2. Is it agonist or antagonist to decrease basically the abnormalities in mitochondrial dysfunction, ALD. So there's all these happening. So there is still a lot of excitement, but unfortunately, at the end of the day, the one thing that works is, fortunately, bone marrow transplant works really well for the kids. Unfortunately, it works for adult men, and so we really don't really have yet a good therapy in adult men. That's why we are doing all these trials. So I'm going to stop there. Thank you.